The different classes of insulin that exist when managing a patient with diabetes, we have rapid-acting insulin, we have short-acting insulin, intermediate-acting insulin, and then long-acting insulin. So at this juncture, what I see in my practice a lot is the use of your rapid-acting insulin as well as your basal insulins again, and now a shift towards probably your newer generation basal insulins. And so what that allows you to do, and a combination of that, and the reason I mentioned that basal bolus is because it's a very common approach that's used in terms of management of blood sugars. Basal insulin, some of the newer generation basal insulins include Toujeo, Tresiba. Other ones that you may be familiar with include Lantus, Levemir. They provide a basal amount of insulin that covers you pretty much for the 24-hour period. And then whenever a patient consumes a meal, you need to cover that meal through a rapid-acting or short-acting insulin, which they would use prior to a meal to cover the glucose excursion that that patient would have after consuming a meal. And so that's the traditional basal bolus approach when you're thinking about insulin management. The shorter-acting insulins and the intermediate-acting insulins, again, are less seen now for a variety of reasons. They have a little bit more hypoglycemia associated with them. They need to be injected more frequently. And so for that reason, you're seeing some of the shift in terms of newer generation basal insulins. When we think of insulin therapy, traditionally what happens is a patient will get started on a basal insulin. And the reason being is the basal insulin is going to help bring down a patient's fasting plasma glucose. And they always say treat fasting first. And so patients will typically get started on a basal insulin to bring down their fasting plasma glucose. After a certain point, 1 in 2 patients that are on a basal insulin won't actually get to goal because it's done a great job in lowering the fasting plasma glucose, but their postprandial glucose readings are high. And so in those situations, they're going to need something else to lower that blood sugar that happens after consuming a meal. And that's where your rapid-acting and your short-acting insulin becomes very important, and those usually might get added on after a patient has been optimized on a basal insulin. And for that, you might be looking at a patient's logbook and seeing that their fasting numbers in the morning are fine, they're waking up within range, but their A1C is still elevated. And if the patient were to check their postprandial glucose after a meal, you'll probably notice that it's elevated and not within goal. And so then you would adjust that dose to that meal and making sure that those excursions don't happen to then again improve that glycemic control for that patient. When you think about insulin intensification, there's a lot of different factors that go into it. For patients that are being seen by the local pharmacies, it's very easy to figure out what amount of insulin the patient's on and how quickly they're being titrated to their target dose to get to that fasting plasma glucose range. But what I also see happen a lot, and where I think pharmacists can intervene, is the exact opposite, where there is too much insulin intensification when we're talking about basal insulin, and you'll hear the phenomenon of over-basalization. So 1 in 2 patients that are on a basal insulin will actually not get to goal on just basal insulin. So meaning that they're going to need something else to treatment intensify outside of just their basal insulin. And that weight-based dosing is around 0.5 to 0.7 units per kg for a patient. And again, the reason I'm mentioning the weight-based dosing is most are not done weight-based. And everyone is taught and it's perceived that insulin has no max dose, but there is, where you're going to see a rate of diminishing effect in terms of lowering blood sugar. And at that point, it makes sense to add another short-acting or rapid-acting insulin or switching to a different class of an injectable to treatment intensify.